Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along and they'll be addressed. I am honored to introduce our mentor for today, Dr. Wafia Afridi. Dr. Wafia Ali Afridi is a board-certified physician in both internal medicine and rheumatology. She is an active member of the American College of Rheumatology. She earned her medical degree from the Aga Khan University Medical College and completed her residency in internal medicine at the University of Connecticut Health Center in Farmington, Connecticut. She subsequently completed her fellowship training in rheumatology at the Warren Alpert Medical School of Brown University in Providence, Rhode Island. After completing her rheumatology training, Dr. Afridi worked at a rheumatology practice in Hampton, Connecticut, until she moved to Dallas, Texas in 2018. She strongly believes in fostering long-term trusting relationships with her patients and taking a patient-centric approach towards their care. She values patient education regarding their condition and treatment options and is excited to serve her patients and community. Dr. Afridi and her husband share 3 beautiful children. She enjoys reading and traveling with her family. And now it is my honor to request Dr. Afridi to begin today's session. Thank you.
There we go. So sorry about that. Hi, good morning. My name is Afridi. Thank you so much for joining us today. We're going to be covering a pretty extensive topic in rheumatology called scleroderma, but I've tried to condense it into kind of the most relative information at this time. So we'll start. Can you guys make sure that you can see my screen okay? Is there any way you can let me know? Okay.
Yes, we can see it.
Okay, great. All right. So what is scleroderma? So basically, scleroderma refers to a chronic multi-system disease, which has 2 large characteristics. There's widespread vascular dysfunction, and then there's a progressive fibrosis of the skin and internal organs. The word scleroderma comes from the Greek word scleros, which means hardened or thickened skin. So basically, thickened and hardened skin is one of the hallmark features of systemic sclerosis. Systemic sclerosis is the name which encompasses the skin thickening along with the internal organ dysfunction. So this is just a brief schema as to, the pathogenesis of how this comes about. Most of, rheumatic diseases have an autoimmune pathogenesis to them. This is one of the diseases where we don't tend to see too much of an inflammatory process occur, but we do know that, circulating lymphocytes make their way through the endothelial cells, and that then eventually leads to triggering fibroblastic dysfunction. The fibroblasts then go on to deposit fibrous tissue within organ systems then. So scleroderma is classified, or systemic sclerosis rather, is classified into 4 large categories. The first one is called limited cutaneous systemic sclerosis. Then we have diffuse cutaneous systemic sclerosis, scleroderma. That's like a tongue twister right there, and systemic sclerosis with an overlap syndrome. And we'll briefly talk about each of these. So this is just kind of a schematic presentation of the salient or the large features that are usually present within each category, but we'll go into these in a little bit more detail. So in limited cutaneous systemic sclerosis, one of the initial presenting features are puffy fingers distal to the MCP joints. So basically the hand, knuckles, and distal, including the fingers. This ultimately will develop into skin sclerosis or thickening, which involves areas of the body distal to the elbows and the knees, and face and neck. We infrequently see trunk and proximal extremities involved in this type of systemic sclerosis. We see a prominent vascular manifestation. The main one is Raynaud's phenomena, and we'll go into that as well. We typically see mucocutaneous telangiectasias. These patients usually also have some presentation of pulmonary arterial hypertension, and very frequently we see a syndrome called the CREST syndrome. CREST basically stands for cutaneous calcinosis cutis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasias. This is a picture of what Raynaud's looks like in the fingers. So basically it is, a complete loss of blood flow for a certain amount of time leading to in the distal digits, including fingers and toes. It leads to this whitish looking tip of the finger. Sometimes it can involve more of the finger or the full finger. It's not always symmetric. It can involve one or all the digits at the same time. And it is a reversible phenomena. So you end up with these white tips. And then as time goes on, they end up turning kind of bluish because of the loss of blood flow. And then when the blood flow returns, the hands end up looking very dusky and purple. This is a picture of someone who has developed mucocutaneous telangiectasias. She also has them on her face, but if you look at her tongue here, she has these red spots, which are basically vascular malformations within the mucocutaneous layer here. You can also see them on the skin as well. All right, the second type that we're going to talk about is diffuse cutaneous systemic sclerosis. This also presents with puffy hands, which go on to develop skin thickening, but this time the skin involved is much more extensive. The skin thickening extends proximally and involves not only the distal extremities, but also the upper arms, thighs, and you can see this also in the face and trunk. So it's a more extensive skin involvement. Patients with diffuse cutaneous systemic sclerosis are more likely to have rapid progression of the skin thickening and early development of lung fibrosis. And they also have an increased risk of something called scleroderma renal crisis. They also tend to have more cardiac involvement as well. Now, systemic sclerosis, since scleroderma, get this out of my view, is a small subset of patients that have no detectable skin involvement, but they have all of the internal organ involvement and, autoimmune antibodies that are specific for scleroderma present. So it's essentially diffuse cutaneous systemic sclerosis, but without the skin involvement, which is And then systemic sclerosis with overlap syndrome are basically a subset of patients who have systemic sclerosis or any of the above subsets, either diffuse, limited, or scleroderma. But then they also have overlapping features with another systemic autoimmune disease like rheumatoid arthritis, lupus, polymyositis, or Sjogren's disease. So who gets scleroderma? So studies have shown that the incidence of new patients developing this disease are about 8 to 56 new cases per million persons per year. So it is a very rare disease to develop. The prevalence currently is reported as 38 to 341 cases per million persons. We definitely see a predominance of females developing this disease compared to males. Women who develop scleroderma usually have a more limited disease. They present at a younger age of onset, and the frequency of peripheral vascular disease and risk for pulmonary arterial hypertension is usually higher. In men with scleroderma, they usually present with a diffuse cutaneous disease, so more skin involvement. They have more frequent incidence of interstitial lung disease, ILD. You tend to have more cardiac involvement and renal crisis. We definitely see African-American patients have a larger predominance to developing this disease. They have an earlier onset of their symptoms, and they usually have a more severe disease phenotype as well. Let's start with the clinical features. So we've got two large categories, the skin features and all the other organs. We'll talk about the skin features in a minute. So generally, when somebody presents with an autoimmune process or a disease, they tend to develop or report a significant amount of fatigue, despite sleeping well, eating well. So fatigue is one of the hallmark symptoms of this process. They will present with pain, and this pain can include pain in the joints, pain in the skin, Raynaud's phenomena causing digital ischemic ulcers and therefore pain. So pain is also a big hallmark of this disease. And then we'll go on to see other organ involvement and then symptoms arising from that organ involvement. So when we talk about the skin manifestations or the skin features of this disease, it's usually present universally across the board, except for if you are presenting with scleroderma skin sclerosis. It presents in a variable extent. Usually the fingers, hands, and face are the earliest involved areas of the body. The swelling, so the skin changes usually present as an edematous swelling and an erythema, and that then goes on to become fibrosis and skin induration. Patients who present with progressive skin fibrosis or a very rapidly fibrosing skin presentation usually have been found to be associated with worsening lung function. And this is more commonly seen in diffuse cutaneous systemic sclerosis. So as the skin is now edematous and erythematous, there's more inflammatory cells, coming to those areas. Patients will complain of more itching and edema. We'll start to see some skin hyperpigmentation or depigmentation called a salt and pepper-like appearance. As the fibroblasts start to deposit more and more collagen and fibrin, you'll start to see loss of appendicular hair, loss of sweat glands. The skin will become very dry. And you'll start to see something called capillary changes at the nail beds. So there is a process called nail capillaroscopy. It is something that we can do in the office. It's basically like a really big magnifying glass, and you look at the cuticle or where the nail meets the fingertip, and you can see changes in the capillary shape and the nail beds. We can also start to see ulcerations of the DIP joints and the PIP joints. And that is because as the skin thickens, that joint starts to contract and it cannot move as well. And the forcible movement of that joint can lead to the skin tearing in that area and ulceration development. We also tend to see digital tip ulcers and pitting at the fingertips. And this is because of vascular insufficiency, telangiectasias, and then calcinosis cutis. We'll talk about that. So this is kind of the early stages of scleroderma. You'll tend to see these really puffy hands. And then as the edema starts to go away, the skin will start to thicken, and you will see these shiny areas in the fingertips here as well. We'll talk about digital vasculopathy. It's it's a very commonly associated feature in systemic sclerosis. Raynaud's phenomena is usually always present in patients with systemic sclerosis. It's basically a reversible vasospasm due to functional changes in the digital arteries of the hands and feet. So if you remember that little slide about the pathogenesis, you'll see lymphocytes passing through the endothelial layer, activating fibroblasts, which then go on to deposit a lot of collagen and fibrin. So this leads to fibrin deposition within even the endothelial layer in the vessels. Now, this is usually a reversible vasospasm, but as this process occurs more and more frequent, these vessels tend to develop permanently impaired flow. And as the longer the episode lasts, the more the chronic changes or irreversible changes start to happen. So for episodes lasting more than 30 minutes, patients can end up with ischemic pain in their fingers, which could lead to digital ulceration, and eventually ischemia and infarction in those areas. We usually see ulcers in about 50% of the patients with systemic sclerosis. It's more commonly seen in patients with diffuse disease, and those patients also tend to be positive on their labs for the anti-topoisomerase 1 antibody, also commonly known as the anti-SCL70 antibody. People or patients who have a digital vasculopathy also tend to have cardiovascular complications, and this can lead to a decreased chance of survival. Digital ischemia can lead to eventually ulcerations, which can then be super infected, develop gangrene, and sometimes result in amputation. So as you can see here, initially you have this small pitting type lesion at the very tip of the finger because of repeated episodes of Raynaud's. This can then lead to a larger ulceration, and it can also end up in full-on gangrene of that digit. Some of the musculoskeletal manifestations of this disease process include arthralgia, arthritis, tendinitis, because of the fibrosis of the tendons and skin. We can hear tendon friction rubs on exam. And we see a lot of small and large joint contractures also occur in these patients. We tend not to see a frank inflammatory arthritis like we would do with, say, rheumatoid or psoriatic arthritis. The pattern of articular involvement, though, if present, is very similar to that in rheumatoid arthritis. So you'll tend to see a lot of small joint involvement, which includes the DIPs, PIPs, MCPs of the hand joints, similarly in the feet, sometimes wrists and ankles as well. And in patients who do have a very rheumatoid-looking pattern of arthritis associated with their disease, if we see that they are also positive for anti-CCP antibodies, which is a very significant antibody present in rheumatoid arthritis, that's where we tend to see these overlap syndromes occur. So if you were to X-ray any of these joints, or even limbs, the X-rays might reveal calcifications in the skin, and that is called calcinosis cutis. Over time, we can also see resorption on imaging of the DIP or the distal phalangeal tucts. This is a process called acroosteolysis, and this also occurs over time because of loss of blood flow to that area. So these are just some of the contractures that we can see develop in patients with systemic sclerosis. Because of the skin thickening over the joint starts to contract and they are unable to fully extend. You can also see some microtrauma, nodule development, and some ulcerations over those joints where, we're trying to forcibly extend them, or they're unable to do that. This is calcinosis cutis, so it's depositions of calcium under the skin. Sometimes the skin can stretch to the point of developing small tears, and we can see a white material exude from these areas, which is a calcium deposition. And on X-ray, this is the X-ray of the shoulder, and this is the humerus. So within the soft tissue here, you can see these calcium depositions on the X-ray, and this is also called calcinosis cutis. All right, and like I mentioned, many other organs can also be involved with systemic sclerosis. We tend to see a lot of GI involvement. 90% of patients with either of the subtypes have some sort of GI involvement. The esophagus is the most frequently affected organ when it comes to the GI system. Patients will complain of dysphagia, choking, developing heartburn, reflux, which can lead to hoarseness. They also tend to complain of early satiety and bloating, as well as some IBS type symptoms of alternating constipation and diarrhea. We can also see episodic pseudo-obstruction, which is because of the fibrosis kind of forming within the walls of the GI tract, leading to obstruction. Chronic GERD and recurrent episodes of microaspiration can also occur, and this can then go on to worsen or lead to the development of interstitial lung disease, or ILD. There is a specific phenomenon within systemic sclerosis that we see within the gastric antrum, and it's a vascular ectasia or angiodysplasia, and it gives the appearance of a watermelon type of picture within the stomach on EGD, and I'll show you a picture of that. Because it is a vascular ectasia, it's basically abnormal blood vessels or prominent blood vessels within that area, and that can lead to unexplained GI bleeding and anemia in these patients. So this is a picture of an upper endoscopy of the stomach, of the gastric antrum. So you'll see these lines here of those angiodysplasias within the gastric antrum. And because it's kind of like an alternating dark and light patch, it gives this very watermelon skin looking appearance. We also see pulmonary involvement as one of the major organ systems within systemic sclerosis. Some degree of pulmonary involvement is present within 80% of patients. It can vary in range, but usually it falls into two large categories, either pulmonary vascular disease, which can then lead to pulmonary arterial hypertension, or interstitial lung disease, which is also called fibrosing alveolitis or pulmonary fibrosis. PAH tends to occur in about 10 to 40% of patients with systemic sclerosis. So really the presenting complaint in these patients will be dyspnea on exertion. and a non-productive cough. We do see radiologic evidence of alveolitis and early pulmonary fibrosis as well in the absence of respiratory symptoms, but it's not often. A lot of the times we do need to evaluate our patients, and we see functional abnormalities in the pulmonary function testing. So pulmonary arterial hypertension is typically progressive, and if severe, can lead to right-sided heart failure. This leads to other symptoms of heart failure, including thrombosis. So pulmonary thrombosis is actually a late-stage complication. It's pretty common, and it is a frequent cause of death in these patients as well. We can also see cardiac involvement, like I mentioned during the pulmonary involvement slide. It's pretty frequent, but it can be entirely asymptomatic. So we can see myocardial involvement, pericardial involvement, where we have fibrosis of the pericardium leading to pericarditis. And we can also see abnormalities within the myocardial conduction system, leading to rhythm abnormalities. So cardiac complications of systemic sclerosis can be a primary presentation, but they usually occur secondary to underlying pulmonary arterial hypertension, interstitial lung disease, or as a result of scleroderma renal crisis, which we'll talk about next. So 60 to 80% of patients with diffuse cutaneous systemic sclerosis show pathologic evidence of kidney damage. And this is seen as microalbuminuria. On urine testing, we can see a mild elevation in their serum creatinine, and also presenting with hypertension. There is a life-threatening renal involvement called SRC, or scleroderma renal crisis, which is a medical emergency. We see this develop in up to 10% of patients with diffuse cutaneous systemic sclerosis, not so much with the limited cutaneous systemic sclerosis. It usually occurs in the earlier stages of the disease and occurs as an abrupt onset of marked or malignant hypertension. We can see an acute onset of oliguric renal failure, and urinalysis will reveal only a mild proteinuria with a few cells or casts. These patients will also develop, because of renal involvement, microangiopathic hemolytic anemia, as well as thrombocytopenia. They're usually managed in the intensive care unit until their hypertensive symptoms have decreased. We can also at times see some neuromuscular involvement with systemic sclerosis, which basically presents as muscle atrophy or sarcopenia, muscle weakness, and myopathy. And less commonly do we see central, peripheral, or autonomic neuropathies. So it's more of a muscular involvement and less of an actual neural involvement. And believe it or not, you can also have some genitourinary involvement in this disease as well. So systemic sclerosis in men is very commonly associated with erectile dysfunction. This can be an early presenting sign and even an initial manifestation of this disease process. Women with systemic sclerosis can also have sexual dysfunction, and this is usually related to a decreased vaginal lubrication or constriction of the vaginal enteroitus, leading to sexual dysfunction and increased pain. So when we have a patient in whom we are suspecting systemic sclerosis, the first thing we do after taking a very detailed history is to perform a detailed physical exam. So what we're going to see on physical exam is puffy, swollen fingers, perhaps some non-pitting edema of the hands and feet as well. Depending on the time they present, we might see some skin thickening, either in a diffuse pattern or in the limited pattern, limited to the hands, feet, face, and forearms. And when we are suspecting systemic sclerosis, we do something called a modified Rodnan skin score, which we'll talk about. It helps us to monitor clinically and objectively the amount of skin thickening as we move forward in time with the patient. We'll see perioral skin tightening as well, with decreased oral aperture. So as you ask them to open their mouth wide, they will not be able to open their mouth very wide. You can also see digital pitting within the fingertips and sometimes even in the toes, and perhaps maybe some superficial digital ulcerations as well. We can perform something called a nail fold capillaroscopy in the office, where again, it's like a big magnifying glass looking at the capillary loops within the nail bed and the cuticle. And there you'll see dilated capillary loops, capillary dropout, meaning loss of capillary loops within the pattern, and microhemorrhages. We might also find that the patient has calcinosis cutis, which can be present in the hands, elbows, knees, mucocutaneous telangiectasias, and perhaps even some cutaneous hyperpigmentation. We can hear and feel tendon friction rubs on exam as well. So this is the modified Rodnan skin score. So basically in normal skin, you can pinch skin and see wrinkling happen. And this is skin that has an appropriate amount of collagen and fat and tensile strength. And as fibrosis increases, the amount of skin that you can pinch over time will decrease. So basically, this is how we quantify how much fibrosis is present, A, B, C, or D. This will give you an idea of how much skin you can pinch. And then you score that against all of the areas involved. So 0 would be a part of skin that is uninvolved, 1 is mild thickening, 2 is moderate, and 3 is severe thickening. We start with the face and we score how much thickening we see, upper arms, anterior chest, go on to move into the abdomen. Then we can do the forearms, the hands, and the fingers. And as you can see, because there's a lot of differentiation between diffuse and limited, we are focusing a lot on how much of the distal extremities are being involved. Thigh, leg, foot, and we will do this on both sides of the body. We then add up all of the score, and a score of greater than, I'm going to say, the maximum score you can get is 51. I believe a score greater than 19 usually relates to a significant amount of thickening. So this is just a clinical assessment of the skin thickening. All right, then we go on to doing some lab testing. So in autoimmune diseases, there's been a lot of progress made when it comes to antibody testing and being able to measure these antibodies within our serum. This gives us a lot of information in terms of making a diagnosis and also moving forward to monitor disease activity as we provide different treatments. So you want to start out with some basic lab testing, which would include a CBC, on which you could possibly see an anemia due to either malabsorption, iron deficiency, or even GI blood loss that the patient is unaware of. You for sure want to check the kidney and kidney function and liver function. You might be surprised to see an elevated serum creatinine level. In patients who have involvement of the muscles, we check a creatine kinase, an elevation, and that could lead us to suspect some myopathy or myositis in this patient as well. A urinalysis with urine sediment is also very helpful and probably very essential. If you see an elevated serum creatinine level, you want to get a UA to check for proteinuria and or casts, because that can also change the differential for you. And then we tend to do an ANA test. So an ANA is basically stands for anti-nuclear antibody, and it is what is kind of the grandfather antibody in most autoimmune diseases, meaning that it is present over a variety of autoimmune diseases. It is present positive in approximately 95% of the cases with systemic sclerosis. If it's negative, the chances of this actually being systemic sclerosis is very low. There are some people who carry a low titer positive ANA based on their genes or relationship to other family members who might have an autoimmune disease. But most of the time in systemic sclerosis, if it's present or positive, there's a 95% chance they have systemic sclerosis. And then we also go on to check very specific antibodies for systemic sclerosis. The top one is called anti-deoxyribonucleic acid or anti-DNA topoisomerase 1, commonly known as SCL70 antibody. We also can see an anti-centromere antibody present in the lab as well as an RNA polymerase 3 antibody. And we see this the RNA polymerase 3 antibody present in patients who have diffuse cutaneous systemic sclerosis. And it is kind of a predictor of rapidly progressive skin involvement and risk of developing scleroderma renal crisis. All right. Also, when appropriate, we do check a rheumatoid factor anti-CCP antibodies, both present in rheumatoid arthritis. We will check other antibodies associated with lupus, including an anti-double-stranded DNA, anti-Smith, anti-RNP, complement levels, to make sure that we're not missing an overlap syndrome of some sort. Okay, so here you'll see that the A&E pattern within diffuse cutaneous systemic sclerosis is usually speckled. With limited, we'll see it as a centromere type pattern. We tend to see the anti-SCL70 antibody present in 10 to 40% of cases who have diffuse cutaneous. We'll see anti-centromere antibodies present in about 15 to 40% of those with limited cutaneous systemic sclerosis. An RNA polymerase 3 antibody, we usually see more with diffuse. So when you're dealing with the diffuse type of sclerosis, you want to make sure that we check the SCL70 RNA polymerase 3 antibody, and in limited, which, where we see the CREST syndrome, more in women, like I previously mentioned, we'll see more commonly an anti-centromere antibody. It is possible though, to have all three antibodies positive within the same patient. Okay, so other investigations after lab work. So all patients with suspected systemic sclerosis should be evaluated for pulmonary involvement. And that usually happens by taking a history, determining any symptoms, performing PFTs that might note a low diffusion lung capacity of carbon monoxide. You can start with the baseline chest X-ray, but generally speaking, a high resolution CT of the chest is preferred. You will see more changes of ILD on an HRCT. And then we do a cardiac evaluation, especially a Doppler echo of the heart, to evaluate for any sort of elevated right-sided pulmonary pressures that could lead us to think that the patient might have pulmonary arterial hypertension. And these are actually things that we perform yearly in patients as monitoring as well. Every year we'll get an HRCT of the chest, PFTs, and an echo. When you suspect GI involvement, or even if once at initial diagnosis, we will do a baseline EGD at times, just to look for vascular ectasia in the antrum, gastric antrum, any sort of stricture formation within the esophagus that would lead to dysphagia. Some patients have difficulty with gastric motility, and therefore a gastric emptying study is also helpful. So this is all part of initial workup. Okay, then we come to the skin. Now we've examined the skin. We've done we've done a Rodnan skin score on them as well. But is it necessary to do a skin biopsy, or can we just make a visual diagnosis? So sometimes it is necessary to help differentiate this disease process from other syndromes that might look very similar, and those include eosinophilic fasciitis, sclerodema, and scleromyxedema. So if we were to perform a skin biopsy, and we need our dermatology colleagues to help us with that generally, in the early stages of disease, we tend to see a lot of edema within the dermis. There's a variable degree of perivascular mononuclear inflammatory cell infiltration, and also some fibrosis that's beginning to occur. As the disease process goes on, we'll start to see that the intradermal white adipose layer is starting to atrophy and shrink. And sometimes it's even completely absent and is replaced by fibrotic tissue. So we'll start to see loss of normal skin architecture and replacement with fibrotic tissue on microscopy. And then later on, towards the later stages of disease, if you were to biopsy the skin, you would see excessive deposition of compact and organized bundles of collagen in the dermis and expansion of the dermis. Now, because this is not a very inflammatory driven process in the beginning, or at least once fibrosis starts to happen, doing direct immunofluorescence studies on skin tissue after biopsy is usually negative in these patients. Okay. All right, so the ACR, which is the American College of Rheumatology, and EULAR, which is the European League for Rheumatic Diseases, has come up with a criteria for the classification of systemic sclerosis. And this classification criteria is not only to diagnose, but mostly to determine entrance or admission into clinical studies, so that we kind of have a baseline with which to accept patients into clinical studies. So there's different things involved here. The first component is skin thickening of the fingers of both hands, extending proximal to the MCP joints. And this holds a weight of 9, or a score of 9. Then it goes on to involve skin thickening of the fingers only. Is it just puffy fingers for a weightage of 2, or is there some sclerodactyly of the fingers, which is basically kind of this change in shape of the fingers? They become very pointy and they start to lose collagen and tissue and bone in those areas. That will give you a score of 4. You can see they've also included fingertip lesions as ulcers or pitting scars, telangiectasias, abnormal the nail fold capillary seen on capillaroscopy, pulmonary and arterial hypertension, and or interstitial lung disease. And depending on which one you have, you score it accordingly. Is Raynaud's phenomena present or not? And then antibodies on lab testing. Any of these will give you a score of 3. So basically, these are applicable to any patient that's being considered as for inclusion in a study. Well, it does have some drawbacks to it, in the sense that it's not applicable to patients who have skin thickening sparing the fingers. So basically trunk involvement, and not so much of the distal extremities. Or in patients who have skin thickening due to other disease processes like nephrogenic sclerosing fibrosis, morphia, eosinophilic fasciitis, sclerodema, etc. And basically any score, if patients have a score of greater than 9, they're classified as having definite systemic sclerosis. And even just, showing up with the top symptom here will, they'll meet that criteria of having greater than 9 or equal to or greater than 9 score. All right, so now we come to the treatment of systemic sclerosis. We've made a diagnosis, we had a suspicion, we made a diagnosis, and now, what are we going to do about this? So because the etiology and pathogenesis of systemic sclerosis are so poorly understood, and it's not a very inflammatory driven process, the treatment of these conditions is difficult. It's incomplete and it's not curative. So it's really just managing the disease process as best as we can. We do not have a curative treatment for it at this time. So the first thing to do is to determine the disease subset. Is this limited disease or diffuse disease? Once we've determined which category the patient falls into, we then want to assess the severity of that category. Is there any organ involvement and dysfunction? Is there any potentially reversible inflammation occurring? Or are we at a point where the patient has sustained some irreversible fibrosis or necrosis? All right, so we'll talk about the skin treatment, but first we're going to go over the organ targeted therapies. So if you determine that a patient does have organ involvement of systemic sclerosis, therapies are usually targeted towards their symptoms in those specific organs. For example, if they have GI involvement, which could show up as GERD, dysphagia, we want to put patients on a PPI or a prokinetic agent. Some patients do need periodic dilation of the esophageal structure via AGD. You do want to have them establish care with the GI doctor as well. For patients who have a lot of Raynaud's phenomena, we've found benefit in placing them on a calcium channel blocker, nitrates and vasodilators, in order to reduce the episodes of spasm and therefore any long-term complications with decreased blood flow leading to ulcerations. Sometimes we also need to get wound therapy involved to help any ulcerations that have already occurred. In patients who have renal involvement, aggressive blood pressure control, putting them on an ACE hit inhibitor has been found in studies to be very beneficial. And then if they end up with a hypertensive renal crisis, inpatient admission and aggressive blood pressure management there as well. Patients with pulmonary involvement, depending on which category they fall into. So if they're the ILD category, we have found that some immunosuppressants are beneficial to that, but if they fall into the pulmonary arterial hypertension, right-sided heart failure category, then we're going to target our therapy towards that, which would include diuretics, inotropic agents, in order to improve heart contractility. We might consider putting them on anticoagulation therapy because these patients are predisposed to developing thrombosis, which could, lead to a PE as well. And then also placing them on phosphodiesterase inhibitor therapy, which is again another agent that is helpful in causing vasodilation in those vessels. Patients who develop arthralgias and arthritis or might have an overlap syndrome can benefit from NSAID therapy, hydroxychloroquine, also known as Plaquenil, or methotrexate. So we would treat them similar to having, any other autoimmune arthritis prior to going on the biologics. Patients who have inflammatory myopathy can benefit from steroids, methotrexate, azathioprine as a steroid-sparing agent. And then patients who have cardiac involvement, including pericarditis, myocardial fibrosis, and myocarditis, usually are very closely followed by cardiology. And there are various treatments that we can do for that, including pericardial windows, pacemakers, if they have conduction problems as well. And then in the patients who are presenting with erectile dysfunction, giving them long-acting PDE5 inhibitors is also very beneficial. Okay, so when we have skin disease, now whether it's diffuse skin involvement or limited, whether we have severe inflammatory organ involvement or not, we do try to treat the skin involvement aggressively. And this is because we might not be able to cure it, but treating it aggressively can slow it down to the point where we might be able to prevent some internal organ involvement as well. That would, for sure lead to complications and organ failure. So who are the candidates for this type of aggressive therapy? Those would include patients with a diffuse skin involvement that's very severe or progressive, those who have known ILD or myocarditis, and those who have known myopathy and arthritis at presentation. So for patients who don't have any organ involvement, but just a progressive and diffuse skin involvement, we have found some benefit with putting them on, treating them with methotrexate or mycophenolate mofetil. These are both steroid-sparing agents. They're also immunosuppressants, and we have found some benefit to skin with that. Methotrexate kind of also helps if they have arthritis and myositis. So it's kind of we'll cover multiple things besides the skin. We'll choose MMF for patients with significant interstitial lung disease and skin involvement. And then we've also found studies have shown some benefit to the use of cyclophosphamide for progressive skin involvement in patients who are refractory to treatment with either methotrexate or mycophenolate. So it's not always used as a first-line treatment, but rather a second-line treatment or for rapidly progressive skin thickening. Okay, there have been some studies or some case reports where IVIG or rituximab, which is the B-cell inhibitor, have been used in refractory cases and have had some benefit, but this is not something that we typically do all the time. So what is a prognosis in these patients? Patients with systemic sclerosis have a substantial increase in the risk of death because of internal organ involvement, usually. Cardiac causes, pulmonary fibrosis, pulmonary arterial hypertension are the leading causes of death in these patients. Renal disease, at times malignancy, GI disease, and infections can also be other reasons for increased morbidity and mortality. And we've found that the presence of topoisomerase 1 antibody or anti-SCL70 antibody and or the anti-TH or TOE antibodies are associated with an increased mortality. Male sex, because they tend to present with more diffuse disease at a younger age at disease onset, may also be associated with increased mortality in these patients. So in summary, it's a pretty large range of disease processes. But in addition to the skin fibrosis and thickening leading to other complications, really what we're trying to prevent and slow down is irreversible damage to the internal organs, because that is where most of the mortality lies. And as of now, despite, rheumatology making great strides and progress in terms of immunologic therapy and biological therapy, we still haven't gotten very good treatment options for systemic sclerosis. It is a pretty rare disease, and that might be one of the reasons why we don't have as much treatment options. You have to have a large population, or you would prefer to have a large population of patients with a certain type of presentation and disease in order to study them with different treatments, and then we can determine, what's working, what's not. But because it's a pretty rare disease to begin with, our population of patients that we can study is also very small. But hopefully in the future, we will come up with something that will give a significant benefit, not only to the skin manifestations, but preventing any internal organ irreversible damage as well. All right, well, thank you so much for your attention, and I would be happy to take any questions at this time.
Thank you. Thank you for your mentorship and teaching, Dr. Afridi. My name is Grace Wankwo, and I will be leading our Q&A session for today. Okay. So my first question is there any way that we as young adults can prevent rheumatoid arthritis now with more exercise, stretching? Is there anything we can do to prevent this for our future?
So all autoimmune diseases, whether it's rheumatoid arthritis or scleroderma or lupus, basically doesn't, the pathogenesis of these things is still something that we've learned a lot about, but there's still a lot of learning to be done. It's not a one-hit phenomenon. Basically, you have to have a genetic predisposition, lifestyle changes, and then something that comes and triggers your immune system into hyperactivity, leading to any of these processes. So your genetic predisposition is not something you have control over. And what the external factor might be that sets off your immune system is also something that is not always well known. It could be infection, it could be stress, it could be a variety of things. But the one thing that is in our control is our lifestyle, right? So leading a healthy lifestyle, preventing any sort of unwanted inflammatory state in your body, which would include, your diet, exercise, stress management. All of these things are helpful in terms of decreasing your chance of your immune system becoming active in the right situation, like the perfect storm needs to happen for your immune system to trigger, is always a good idea. But we don't have evidence that 100% of the time you can prevent something like this from occurring by just exercising, having a clean diet, meaning avoiding processed flour, sugar, inflammatory foods, and decreasing the amount of stress that you take, or better stress management. You could do all of those things and you could still get a rheumatic disease. But in order to decrease the severity and the chances of it, it's always helpful to watch your diet, exercise, keep your organs in your body in the best health possible, and manage your stress as best as you can.
Thank you for that. What goes along with that is, why does rheumatoid diseases affect women at a higher rate than men, essentially?
So that's a great question, and I don't know that I have the full answer to that. But I do believe that there is some genetic predisposition to this. So something in the way women's genetic makeup is might contribute to that. I'm not saying this is a completely XY chromosome issue. Having 2 X chromosomes is leading to more rheumatic disease. I don't know that for sure, but there are some HLA associations with rheumatic diseases. So having rheumatoid arthritis, for example, we do see an HLA, DRB1, and DRB4 association with those diseases, and women tend to sometimes carry those things more. The other thing I'm guessing, and I don't have the science for this, maybe we could look it up together sometime, is that any sort of increased inflammatory state will put you at risk for developing a rheumatic disease. Now, women might tend to carry, because of their hormones, a little bit a higher level of adipokines and adipocytes, and that might be a possible, pathway. But it's just, I think it has a lot to do with genetics.
Okay. You mentioned Raynaud's syndrome in this presentation affecting the hands. Are there any preventions to this, or is it the same thing with rheumatoid arthritis, which is it's autoimmune?
Right. So Raynaud's phenomena occurs because of this reversible vasospasm. And in order to prevent episodes of it, we for sure ask our patients always to keep their extremities warm, even in the summer, which would include, wearing gloves, double gloved when you're out in the winter, not trying to be under direct air conditioning, because anything that's going to cause your body to feel cold is also going to cause vasospasm. And also, keeping your core warm. So not just keeping your hands warm, it affects the hands, but you want to make sure that your core temperature is also up, because that will prevent distal extremity vasodilation from happening. Vasospasm from happening and vasoconstriction from happening. You want to make sure that you're increasing the blood flow as much as you can to the extremities. And when just these types of measures of keeping your body warm are not effective, we then go on to give patients prescription treatment, which is either putting them on a calcium channel blocker to help with vasodilation, using phosphodiesterase inhibitors, or even topical vasodilating gel. So you would apply that to your fingertips, to your toes, wherever you get your Raynaud's more frequently, in order to increase the blood flow. The more blood is flowing to your finger, the less likely you're going to get repeated episodes of Raynaud's. But we don't have a cure for it. It's just a vasospasm that happens on its own.
Mm-hmm. Are there any neurologic or psychiatric symptoms of scleroderma? I know you said
Yeah, so we're not going to see a lot of nerve involvement per se. Psychiatric diagnoses, I think that in any patients with a rheumatic disease, if they have an increased amount of pain and organ dysfunction, that can lead to increased rates of anxiety and depression in these patients. Being in pain a lot of the time, most of your day, will take a toll on your mental health as well. So it's not typically a presenting feature or an associated feature with the disease process per se, but I think because of their situation, it's more situational, and it is something that we do need to address, because when you are depressed and anxious, your compliance with therapy goes down, your will to do things that would benefit you and benefit your disease process is also low. So in order for you to feel better overall and be compliant with treatment and therapy, we do have to address any anxiety or depressive symptoms in patients who present with those.
Okay. During the presentation, you were talking about scleroderma a lot, and it just occurred to me, regarding women, what if they're pregnant? How would you treat scleroderma during pregnancy?
So honestly speaking, I don't think we see a lot of scleroderma in pregnant patients. It doesn't start to, come up during pregnancy. It's either present prior to pregnancy or develops later on in life when they've kind of crossed their reproductive years. I think with any autoimmune disease, the chance of pregnancy and successful pregnancy is always kind of top of the list, right? In a woman of childbearing age who wishes to become pregnant. Now, if they have scleroderma prior to pregnancy, a lot of these treatments can be harmful to the growing fetus. Some of them, like methotrexate, for example, can cause birth defects and embryo abnormalities. And so we, in young patients like this, young females, we have this conversation before we put them on any sort of therapy that might be harmful to a growing fetus. We have this conversation about their wish for pregnancy and their plans. Now, if this is somebody who knows they want to pursue a pregnancy in the near future, we will hold off on placing them on any sort of treatment that might prove potentially harmful. If this is somebody who is not planning for a pregnancy in the near future, we will counsel them on, the possible effects of this medication on the growing fetus if they were to take it, the need and the importance of birth control during this time, and having a dialogue with them about stopping certain medications at least 3 to 4 months prior to beginning to prepare to conceive. So we want it all out of their system. The other thing I will mention, though, is that the chance of having a successful pregnancy and decreasing the rate of miscarriages and carrying the birth, the fetus to term is always higher in a patient who has a very well-controlled autoimmune process prior to conception. So if we know you want to get pregnant, we want to make sure that your disease is at the very best control that it is, and you're in the lowest amount of an inflammatory state as you can be prior to conception, because that will increase your chances of having and pushing, towards the end for a successful pregnancy. Now, if you were to be pregnant, and your disease isn't under control, really our goal and our focus is to get to the end and have a successful pregnancy. And if we have to treat you with steroids during that time because we can't use any other medications because they're harmful to the baby, we will do that. If we have to take away any sort of immunosuppressant therapy, we will do that. We do have some biological therapy now, for example, for lupus and rheumatoid, that is safe in pregnancy. If you have an overlap syndrome with systemic sclerosis, we can use that. But for systemic sclerosis per se, the topic we were talking about today, we don't have a lot of therapy that would be completely, unharmful to the baby. So we just try our best to get you under really good control prior to conception, and then use steroids and other things that we have during the pregnancy in order to keep you under control. And then once you've had the baby or the woman's had the baby, we can then go back to other treatments. But it becomes tricky for sure, because we want to ensure the health of the mother, the health of the fetus, the best chance at a successful pregnancy. These patients are typically high risk for developing organ complications too, like bleeding, pulmonary complications, cardiac complications. So we typically do work very closely with our MFM OBs, which are the high-risk maternal fetal medicine obstetricians. It's a big group effort in order to get this pregnancy, successfully to term.
Thank you for answering that. Regarding calcinosis cutis, how do patients typically manage with this conditions?
So it's really hard to manage these. Basically, we don't have anything that's going to resorb them or improve the size or the look of them. But if we can get your overall disease state under control, it can slow the process down of developing larger depositions. So we want to determine the severity of your disease and then try to get that under best control. If we do have lesions that are open and weeping, or the calcifications are kind of present over joint lines where it's preventing extension flexion of the joints, they can be removed. So we can send them to plastic surgery or to dermatology, and they can have them excised. But they're usually pretty widespread, so it's hard to excise each one of them. We just want to focus on the larger ones, or the ones that are causing significant day-to-day impairment, and we can excise those and remove them. They do tend to recur, though, if your disease isn't in a very active state.
Thank you. And our last couple of questions are related to your residency experiences. First, why did you choose to pursue a fellowship in rheumatology following internal medicine?
So, internal medicine is, it's a great specialty to just, on its own, it's a great place to be. You get to see a lot of different kinds of disease processes and manage a variety of patients, head to toe, all organs. But I kind of felt like I wanted to dive deeper and just know a whole lot more about a very specific niche, rather than, trying in my mind to keep up with like everything head to toe on a kind of not a surface, but like a primary care level. And so I knew I wanted to do a specialty of some sort, even going into internal medicine. And then honestly speaking, it was a little bit of a process of elimination. I knew the things that I didn't want to do, and I made those choices based on, the kind of life I wanted to have. Because when you're a college student, a medical student, a resident, your schedule is not in your control, right? You are at the mercy of, deadlines and dates and rotations and exams. And I didn't want that to be my life forever. I wanted to be able to have some control over my day-to-day. This was kind of a big investment in time that I was putting in up front. And then I wanted to see kind of that return on investment in the future. And so I eliminated some specialties just based on how much time I would have to give to them. So cardiology, pulmonary, GI, things that I would have to wake up in the middle of the night and drive to the hospital for. There's a thrilling sensation to that too, when you get called at 2 a.m. and somebody needs you and you have to go in there to cath them and put a stent in. But during residency, when you do your ICU rotations, and I did residency back in the day when we still had 30-hour calls, they've eliminated that now. So, I mean, it's fun and exhilarating at the time, but like as a long-term, every day of your life or every 6 weeks of your life is going to be like this, I didn't think that I physically had it in me to do that. So I kind of eliminated the specialties that would require me to be in the hospital in the middle of the night. And I was kind of left with, endocrinology, rheumatology, infectious disease. And I realized that I wanted to do something that also involved some procedures. So rheumatology is procedural in the way that we can do joint aspirations and joint injections, and they're office-based procedures. And that's not something that I would have found in endocrine, for example, or infectious disease. And so I kind of narrowed it down to, I don't want to be up in the middle of the night. I want to do something that's purely outpatient based, mostly outpatient based. There is an inpatient component to rheumatology, and that is procedural as well. The other thing that really, really piqued my interest was when I did a rheumatology rotation during residency. There's just so many new medications and treatments out there now. So with the increase in knowledge about immunology and immune-mediated pathways, there's been a lot of progress in developing immunotherapies for cancer, and for rheumatologic diseases. And it really, really intrigued me as to how many more options we had in order to benefit patients and their disease processes. So I think that's what kind of led me to a process of elimination led me to rheumatology, but then it really piqued my interest with all of the immunology and the new medications and the new treatments we had, as well as the procedural aspect of the specialty. And it would allow for me to be able to do this mostly as an outpatient during the day, 9 to 5. Mm-hmm. And I would have my protected time, with my family in the evenings and at night. So just the balance of all that together, I think was a good fit for me.
Yeah, that's crazy. 30-hour on call. That's
crazy. I think 2 years after, so I was a third-year resident, I think, and the new interns coming in didn't have to do 30 hours. That was like the first year they stopped it. Yeah. But we'd done our time. We'd done our 30 hours at that point. Yes. But it's an experience. It really, it shows you the resiliency of the human body and mind. But at the same time, I don't think it's a long-term physical situation that anybody should be in. It really affects your physical health, your mental health, and then that goes on to impact patient care, which is what our priority is. So overall, it's a good decision not to have those anymore.
Amazing. Do you have any advice or further resources for students like me who are interested in learning more about pursuing a career in medicine and rheumatology?
So I think that actually just spending time with physicians in the office and seeing what the day-to-day looks like is really, really helpful. And the more experience you can gain in seeing all aspects of it, experiencing all the different specialties of it, the really fast-paced, thrilling aspects and the really mundane day-to-day office-based stuff, I think it's really important that everybody's, if you're interested in a career in medicine, that you experience the full spectrum of these things by shadowing other physicians, volunteering at hospitals, and getting as much exposure to this as possible. Medicine is a career of passion. You really have to enjoy what you do in order to do this. And I say this because you're not going to be a good physician and be able to help anybody else if you yourself are not in that mental space where you really love what you do. It's hard. It's physically taxing. It can be really depressing sometimes when you're dealing with a lot of death and disease. Things are not always within your control. So you really want to be at a place mentally where you love what you do and you find it rewarding and fulfilling. So as much exposure to that as you can get by shadowing other physicians, being in the hospital, being in the clinic, I think is always a good idea. If you want to learn more of the science, we are scientists, we want facts, we want data, we don't want just speculation. It's always, great resources online are available. We use uptodate.com a lot. We have a lot of latest, there's a group of doctors who put together all the latest research and then, kind of put out lecture form information there. You can go to pubmed.com where there is the latest published research. You can find a wide variety of topics and articles covered there. If you attend ACP meetings, so ACP is the American College of Physicians, and they kind of have meetings for different specialties over the country, and they have on different times of the year. They usually have everything listed on their websites, and you can attend as a student. For discounted prices, if something is close to you in a city that's happening with you, just to kind of get an idea of what is the scientific progress and research that's happening within different specialties, within different societies in medicine, just to give yourself an overall big picture. If you find it interesting, you're passionate about helping people, you get a sense of not just gratification, but like personal satisfaction from helping people, then healthcare for sure is a great field to be in. But just like any other profession, you want to make sure you have all the information or as much as you can gather prior to committing yourself to it, because it is a long road. It is a lot of time and effort that you put in. So you want to make sure you're making the right choice.
Thank you very much, Dr. Afridi. Those are all the questions we had for you today.
Okay,
we would like
great.
everyone to give a warm thank you to Dr. Afridi in the chat box for her informational session. Thank you so much.
Thank you for having me. Take care.
Now we're going to conduct our closing session with our quiz and future dates. The link to the quiz for this session is now live. You'll need a 70% or higher to pass and receive certification. Now on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next live session will be next Saturday, August 26th at 10 a.m. Eastern Standard Time for our final rheumatology session of the month. Thank you so much, everyone, for attending today's session. We hope to see you in upcoming sessions. This concludes this week's shadowing session. Thank you.